Good morning students, I am Dr. P. Tharani, working as an assistant professor in Department of Oral and Maxillofacial Surgery in Vinayaka Mission Sankaracharya Dental College. Today I am going to talk about frenectomy. Contents are: what is frenum, etiology of abrasive frenums, classification, diagnosis of abnormal frenum, syndromes and frenal attachments, indications for the frenal attachment. Let's understand the frenectomy, difference between the frenectomy and frenotomy, and the treatment plan of conventional frenectomy, electrosurgeries, lasers, and my references. What is frenum? Frenum is a mucosal membrane fold which contains the muscles and connective tissue fibers that attach to the lip and the cheek, to the alveolar mucosa, the gingiva and the underlying periosteum. What is frenum? Frenum are various types. One is a labial frenum and a lingual frenum. Labial frenum which attach to the upper lip, and the lingual frenum which is attached to the lower tongue part. And the labial frenum is attached to the upper lip and then mucosa of a upper teeth dentures, and the lower frenum is attached to the lingual frenum which is attached to the tongue and the lower denture region. Is the mucosa gingiva surgery or an periodontal surgery. Mucogingival surgery, a Friedman said surgical procedure for the correction of relationship between the gingiva and the oral mucosal membrane, which is refers to the three specific problem area: attached gingiva, abrasive frenum and shallow vestibules. Is a periodontal plastic surgery? No. Miller says that surgical procedure performed to correct or eliminate the anatomical or developmental or traumatic deformity of the gingiva or an mucosa. The labial frenectomy is done for an aesthetical surgical correction, crown lengthening, ridge augmentation and reconstruction of papilla. What is the etiology of frenum? Frenum is a natural connective tissue which attached to the upper lip and the lower portion of the tongue, where there is maxillary labial frenum. What is maxillary labial frenum? Is a labial frenum when the two incisors erupted widely separately, no bone is deposited inferiorly to the frenum. The V-shaped bony cleft between the two central incisors and the abnormal frenal attachment results. The upper labial frenum which is present between the two central incisors, and the mandibular frenum. Mandibular frenum is attached to the decreased vestibular depth which inadequate to the width of the attached gingiva. Ablative mandibular frenum. Classifications of frenal attachment. Frenal attachment was given by Schwerin classification and Merco et al. Classification. Schwerin classification is in this there is an attachment between the normal labial frenal and then mucosa dental-alveolar region is a normal frenal attachment. Persistent attachment of the labial mucosa. Frenal which attached to the appendix. That frenum which attached to the nodular way. The duplication of the frenum is present in this condition. In this it is a frenal attachment to the nodulus. It is a mild frenal attachment. Mucosa, Mercon et al. Classified into four types: mucosal frenal attachment, gingival frenal attachment and papillary frenal attachment and papillary penetrating frenal attachment. This is the most commonly we are classifying techniques, which is mucosal, gingival, papilla and papillary penetration frenal attachment. What is the diagnostic method of frenal attachment? Two main tests we are following for the frenal attachment balancing. That is our blanch test and tension test. Blanch test, it is mostly done in an upper lip. Upper lip pulling superiorly and anteriorly, and the lip is pulled outward and downward for the maxillary frenal attachment. In maxillary frenal attachment, we will check by superior and anterior. In mandible, it is by outward, downward. Outward and downward shows the mandibular attachment, and the upper shows the superior and anterior retraction. In upper, we can see the midline diastema. Frenal attachment is a pathogen when the unusual wide, no apparent zone of attachment gingiva along the midline. The interdental papilla shift when the frenal is extended. This is a blanch test. In a tension test, it is detected by visualizing the applied tension over the frenal to know the movement of papillary tips. To know the papillary tips of the movement of frenal attachments. What is the syndromes attached to the frenal attachment? Frenal attachment is associated with 6 types of syndromes, which is Ehlers-Danlos, infantile hypertrophic and haloprosocephalic, Ellis-Van-Creveld, orofacial digital syndromes and Pallister-Hall syndrome. What is the problem that we are undergoing in a frenal attachment? That are midline diastema, aesthetic disappearance and tongue tie which causes the slurring of speech, and anterior lobar deficiency. Indications. Why we need to undergo an surgery of frenectomy? In the condition like ablative frenal attachment causes a midline diastema. Midline diastema causes a aesthetic disappearance of a anterior teeth. Ablative frenal attachment causes a gingival recession in and lower anterior region most commonly. Ablative frenal attachment causes a hindrance in the maintenance of oral hygiene. Oral hygiene improper causes a periodontal disease and followed by periodontal infections. Ablative frenal attachment interference with the speech like ankylosing. Ablative frenal attachment indicates the shallow vestibule. Ablative frenal attachment visible as pendicular pieces of tissues in the midline of upper lip. What is the difference between frenectomy and frenotomy? Frenectomy is a complete removal of frenum, including the attachment to the underlying bone. Frenotomy, the incision and the relocation of frenal attachment. Frenectomy is a complete removal of frenal attachment from the one side to the other side, but frenotomy is an incision and relocation of the frenal attachment. Method of frenectomy. There are various methods are available in a frenectomy procedure, that is by using a scalpel, electrosurgery and laser. Different methods of incision that we are making is scalpel, electrosurgery and laser. In scalpel we are having a 3 types, which is a conventional technique, excisional of the frenal through the scalpel is an cost effective, where the electrosurgery is an effective, mild bleeding, absence of post-operative complications. In laser is a safe and effective, short duration of the surgery, simplicity of the procedure, the absence of post-operative infection, less pain, swelling and small or no scar. This is a thing. In electrosurgery we are most commonly using a argon beam coagulation. In scalpel technique we have a conventional classic frenectomy technique. This was given by Archer in 1961 and Kruger in 1964. This is mostly done in a midline diastema condition, which is interference both the central incisor, which involves in the aesthetic corrections. Armamentarium which are required are hemostasis, BP handles, scalpel blades of 15 size, gauze sponge, 3.0 black silk sutures, silk pliers and scissors and periodontal dressing like Copac. In this we have tied out the first operative papillary type of attachment we have found. Papillary attachment is there. This is a papillary attachment which is beyond that is papillary penetration. In this condition we are tagging the attachment area. This is a frenectomy procedure, so we are completely removing the frenal attachment and the suture is done on the upper lip region and the healing, this is an healing stage, post-operative healing. Next, Miller technique. Miller technique is indicated in the post-orthodontic diastema cases. This will be made by horizontal incision to separate the frenum from the interdental papilla. Initially with the horizontal incision followed by excision of the frenum and the exposure of labial alveolar bone in the midline. Okay. Later it will be followed by lateral position of the pedicle graft taken to obtain the primary closure of midline. Then gingivoplasty. Gingivoplasty is an post-operatively the excision of interdental tissue labially or palatally. In this lateral positional technique, it is obtained by the is an primary closure across the midline. Next, Z-plasty technique. It is highly done indicated in hypertrophic labial frenum with a low incision, which is associated with the interincisor diastema and also in the case of short vestibules. Length of the frenum was incised with the scalpel. Initially this is done by scalpel. The submucosal tissue were dissected beyond the base of each of the flap by using the fine tissue forceps. 1 centimeter along the double rotation flap were obtained. Then the result flap is nasolabially and the transition through the 90-degree angulation to the close vertical incision horizontally. Absorbable 5.0 vicryl sutures were used to place the periodontal closure and the periodontal dressing were placed. No hypertrophic or scar formation is noted. Then this is an VY plasty technique. This VY plasty technique is mostly used for lengthening of the localized area in the broad vestibule in the premolar and molar region. VY-plasty incision on the under surface of the frenal attachment. This is done under the under surface of the frenal attachment. The frenal was a relocation and an apical position. B-shaped incision were made, converted into an Y shape. The suture is done by 4-0 silk materials. Periodontal pack were placed. After the 1 month, the frenal attachment is found to be relocated in the apical position with an unusual healing. Then, these are the surgical scalpel technique, which is mainly used are conventional technique, Miller technique, Z-plasty and VY-plasty technique. Next, electrosurgery. Electrosurgery is a minimal invasive. In this, it is mostly recommended in the case of patient with bleeding disorder in non-complicated patients. Armamentarium required are electrocautery unit with the loop electrodes and hemostatic agents. Advantages of this thing when compared to the scalpel is minimal procedural bleeding. There is no need for suturing. This is done very simple method of 3 stages. The frenum is held within the hemostat. It was excised with using a loop electrode tips. The healing was an secondary intervening as the wound edges were not proximated with the suture. Then the most advanced technique is laser. Laser technique is a most commonly used technique nowadays. This is an advanced technique which is used by using diode laser. Diode laser is the most commonly using in frenectomy procedure. Uses of the combination of gallium, arizone along with the aluminum and iridium changes the electromagnetic energy into heat. Diode laser is a high absorbable by melanin and hemoglobin, hence allow the soft tissue to manipulate, accompanies with the improvement of epithelium and wound healing. The diode is used by 940 nanometer of diode lasers are highly used in frenal attachment. Carbon dioxide laser also used in these conditions. When compared to the electrosurgery, laser surgery is a minimally invasive surgery and the hemostatic agent was minimally used and the bleeding and the healing was too earlier when compared to scalpel and electrosurgery. The frenectomy has 3 pattern of surgical procedure, which is scalpel, electrosurgery and laser surgery. Thank you for watching my class.